All right, guys, so today we're going to continue on with our discussion of pharmacokinetics. We're talking about kinetics, so absorption, distribution, metabolism, and elimination. This is focusing on elimination. Elimination refers to drug removal from the body. This can occur by many different routes. The most important route is renal elimination. So when we take the drug from the blood and we get rid of it via the urine. Remember that a drug has to be sufficiently polar or hydrophilic in order to be eliminated from the body. And that's one of the reasons that metabolism occurs. We metabolize drugs into more water-soluble or hydrophilic compounds. There are multiple patient factors that can affect elimination. Think about like a patient who has renal dysfunction. If a patient has renal dysfunction, they're going to have reduced renal clearance, so the drug or the drug's metabolites, if it's been metabolized, can accumulate in the body. We're going to talk through renal elimination in detail. When we talk about elimination in the kidney, the drug can go through multiple processes in the kidney, in the nephron. It can go through filtration, secretion, or reabsorption. We'll talk about filtration first. Glomerular filtration is the passage of drugs from blood in the glomerular capillaries into the filtrate in the capsular space. So remember, like if you look up here, this is the nephron. The nephron is where we filter the blood and produce urine. And there are multiple different parts of the nephron where different processes happen. Right now, we're talking about what happens in the glomerulus. The glomerulus is like in the this like head region. You have the head and then like the body of a snake, right? We're not talking about the tubule, we're talking about just the glomerulus. So if you look here, we've got the glomerular capsule around the outside, and then the glomerulus just refers to this like ball of capillaries that's there in the middle. So blood comes in to the glomerular capsules, and then stuff gets pushed out of the capillaries and into this capsular space. And then whatever's left in the blood inside the capillaries flows out. But we've pushed all of this fluid and solutes out into this capsular space. That is now filtrate. So we had blood in the capillaries, we pushed stuff out, now we have filtrate out here in this space. All that filtrate is going to go into the tubule, right? And it goes through the whole tubule, and as it does, we reabsorb some of the stuff that we want to keep back into the blood. We might secrete some stuff that we don't want, right, into the tubule, and then eventually it makes its way all down, and then it's going to leave the body in the urine. So that's the whole process of what's happening in the nephron. We're looking at just this part right here, the glomerulus. So glomerular filtration is just pushing, fluid, and in this case, the drugs that are present in the blood, from the blood out into the capsular space. Now, this filtration is based on the size of the drug and glomerular filtration rate. Glomerular filtration rate is patient specific, right? GFR is normally about 120 mLs per minute. So this is how much the kidneys typically will filter out in all of the nephrons in both of the kidneys, all put together. Now, if the patient's in renal failure, this amount would be way less, so they would be filtering less of the drug out. Filtration is also influenced by size of the drug. When we're pushing things out of the glomerular capillaries into this capsular space, it's just strictly based on, is it small enough to leave the blood and fit through the capillary wall and make it into the space. If it's too big, it can't fit out. It can't be pushed across that filtration membrane because it's too large. So large drugs can't be pushed out. They can't be eliminated this way. But also protein-bound drugs. Whenever we talk about size, protein binding matters. So if the drug is bound to a plasma protein like albumin, then it's going to be really large and it would not get filtered out in the kidneys. So we said that a drug that's going through the kidney can go through multiple processes. We said filtration. It can also go through tubular secretion. Secretion is when we purposely pump something into the tubule. So it didn't get filtered out at the glomerulus, but we can then later pump it into the tubule so that it can be eliminated from the body. So we already talked about filtration at the glomerulus. Then our fluid is going through the tubule. Remember, there's the proximal convoluted tubule, then there's the nephron loop or loop of Henle, and then there's a distal convoluted tubule. Sorry, the loop and then the distal convoluted tubule. When we're talking about tubular secretion, secretion happens mostly in the PCT, the proximal convoluted tubule, the first little tube that we get to. Tubular secretion is like an active process where we have little transporters that will pump the drug into the tubule. There are a couple different active transport mechanisms that we have here. They pump either anions or cations. Anions are usually the deprotonated weak acids. Remember, we saw like the acid, or we can have the acid with its associated hydrogen. And we said that when the acid has hydrogen, it's happy. When the acid does not have hydrogen, it's negatively charged. So deprotonated acids are anions. And then protonated bases, so when the base has its proton, it's positively charged, so that's a cation. So both of these would be charged. So in this case, they would be water soluble. And we have little transporters that would pump these charged soluble things into the tubule. Now, these transporters have a relatively low specificity. So it's not like there's one transporter that just works on one drug. They're relatively non-specific for either anions or cations. These transporters are underdeveloped in neonates. So brand new babies don't have fully developed transporters in their proximal convoluted tubule. So the implication of this is that they would not secrete drugs as well. Now, secretion is a way that we get rid of drugs, right? We're pumping them into the urine to get rid of them. So in neonates, because they don't perform tubular secretion as well, that's one of the reasons why they eliminate drugs more slowly and drugs can build up. Hence, we use smaller doses. Here you can see just kind of an example of what's happening with tubular secretion. So here we have our blood vessel, right? If you look at this big picture here, notice that there are blood vessels wrapped all around the tubule, right? So the tubule is shown in yellow, and then notice there's all the red vessels that are wrapped all around it. So there's blood vessels in very close proximity to the tubule. So here we see our blood vessel. Right, and then pretty close to that, we have the endothelial cell that lines the tubule, and then over on this side, the lumen of the tubule. So this area over here is inside the tubule. This is where the urine or fluid that will be urine eventually is, so that it's going to eventually leave the body. So we have drugs that can be going through the blood vessel here, and there are active transporters that can grab a hold of that drug and pump it into the luminal cell and then into the urine itself. Once it's in the lumen, it's then making its way through the tubule, where eventually, as long as it doesn't get reabsorbed, it'll make its way into the collecting duct, right, which then gets dumped out into the whole the whole collection system through the kidney, like the minor calyx, the major calyx, renal pelvis, and then the ureter. Drugs can also undergo tubular reabsorption. So this is like movement in the opposite direction. Secretion is when we pump the drug into the tubule and we're going to get rid of it from the body. Tubular reabsorption is when we reabsorb the drug from the tubule back into the body or into our fluids, i.e. the blood. This typically occurs in the DCT, the distal convoluted tubule. That's the last part of the tubule. In order for drugs to be absorbed in the DCT, they have to be lipophilic. And the reason for this is they have to be able to cross membranes. They're not taking advantage of a transporter. So if they're going to cross the tubule and be reabsorbed into the blood, they have to be able to cross those membranes, so they have to be lipophilic. Now, we can manipulate the pH of the urine in order to try and increase the clearance of a drug. Remember, changing the pH changes the state of the drug, whether the drug is going to be protonated or deprotonated. And you guys know that being protonated or deprotonated affects whether or not it's charged. So if we can make that drug charged, then we can try and prevent it from being reabsorbed. So that means we can increase the clearance of the drug. So for example, if we alkalinization, if we make the urine more alkaline or more basic, this will promote the elimination of weak acids. Deprotonated acids are charged. Remember, you can have AH with no charge. That's the acid with its proton, its hydrogen. Or we can have just the acid and it's charged. It's an anion. So if we make the urine more alkaline, we are going to deprotonate this acid, and the acid is going to be charged, which means it's not going to cross membranes, so it's not going to be reabsorbed. This means that the acid will stay in the urine so we can get rid of it. We alkalinize urine, or we make the urine more basic by giving bicarbonate. So giving bicarbonate will promote the elimination of drugs that are considered weak acids. Acidification of the urine will promote the elimination of weak bases. Remember, when we look at bases, the base with its proton with hydrogen is charged. So if we put the base in a really acidic environment, there's plenty of hydrogen ions available. So the base will have this hydrogen ion, it will be charged. If it's protonated, right, or charged, then it's not lipophilic, right? So it won't cross membranes, it won't be reabsorbed. We acidify the urine by giving ascorbic acid. Okay, so patient presents with phenobarbital overdose symptoms. Phenobarbital happens to be a weak acid. Which of the following will promote clearance of the drug? Right, so keep in mind, we're not talking about absorption. This is kind of opposite as when we were talking about absorption. Before we talked about when our drug is best absorbed, and in that case, we didn't want them to be charged, right? Because we wanted them to cross our membranes to be absorbed. But now we're talking about something else. We're talking about elimination. So in this case, we want them to be charged because we want them to get stuck in the urine so that they don't get reabsorbed into the body. So this drug is a weak acid. Weak acids, we said, are better absorbed if we alkalinize the urine. We need to make the urine more basic in order for that weak acid to be better absorbed. When we alkalinize the urine, then remember our acid will be like this. It'll be an anion. So how can we make the urine more basic? Administer ascorbic acid? No, that's going to acidify the urine. Administer bicarbonate to alkalinize the urine? Yes, that sounds good to me. Administer ascorbic acid to alkalinize? No, we want to alkalinize, but ascorbic acid won't do that. It'll make it more acidic. And then bicarb to acidify? No, we don't want to acidify. And by the way, bicarb doesn't acidify. So if we want a weak acid to be better cleared from the body, then we can administer bicarbonate to make the urine more alkaline. That way the drug will be in its anion form. It'll have a charge, so it's less likely to get reabsorbed, and it'll stay in the urine so we can get rid of it. Okay, let's see. A patient is taking amphetamine, which is a weak base. the patient begins taking ascorbic acid because they heard that acidifying the urine prevents UTIs. Which of the following is a likely outcome? So let's just think about this first. The drug is a weak base, and the patient is acidifying their urine. So if you acidify the urine, right, we've got plenty of hydrogen ions available. So the base is going to have a hydrogen ion, and we know that that makes it positively charged. So by acidifying the urine, the amphetamine is in a charged state in the urine. So it's not going to get reabsorbed, which means we're going to clear it from the body more than we would have otherwise. So the clearance of amphetamine will be increased. Yes, the clearance of amphetamine will be increased. The clearance will be decreased? No. The clearance will not be affected? No, it'll be affected. And then the clearance of ascorbic acid will be increased. No, the amphetamine's not affecting the ascorbic acid, right? It's the weak base, the amphetamine, that we're actually worried about changing. So the clearance of amphetamine would be increased, so the patient might have less of an effect from the amphetamine. So total clearance from the body is the result of all metabolism and all elimination that's occurring. We talked about metabolism in the liver, and then there's excretion by the kidneys, right? And those two are the most important thing, metabolism in the liver and excretion by the kidneys. But there are other ways that we can eliminate drugs from the body. Drugs can be eliminated in the feces. So this happens in a couple different ways. This can happen to drugs that are given orally but are not absorbed. So vancomycin is the big one here. We typically give vancomycin, it's an antibiotic. We give it IV if we're treating an infection anywhere besides the GI tract. But we can use vancomycin for gastrointestinal infections. We use it for C. diff, for example, Clostridium or Clostridioides difficile. So we use vancomycin for it in the infections in the GI tract. So in that case, we would give vanco orally because it's going to stay in the GI tract. It's not going to be absorbed. So we're essentially giving the drug directly to the site of action. So the drug stays in the GI tract though, so eventually it's going to be eliminated in the feces. Drugs can be eliminated in the feces if they get secreted into the intestine. Again, this is not very common, but possible. The most common way that drugs get excreted into the feces is if they get excreted in the bile. Remember that the liver cleans out the blood and it puts wastes in the bile, and the bile gets excreted into the small intestine. And then if you follow the small intestine down and around, eventually you go through the large intestine and then out of the body. The lungs can also be a site of elimination. This is primarily the elimination of gases. So the anesthetic gases that we use, for example, like when patients are having surgery and they're going under, we have them breathe in the drugs. The drugs are in gaseous form. And in that case, the lungs can be a primary site of elimination, but this isn't very common for other drugs. Some drugs can be excreted or eliminated via the breast milk. So excretion in the breast milk is not typically a major path of elimination, but it can be enough to be important for the infant. So even if just a little bit of the drug is being eliminated in the breast milk, realize that that infant is so much smaller that that little bit can end up being a really big dose for the infant. So this can lead to adverse drug effects in the infant and is something to really watch out for if you are giving drugs to a woman who's breastfeeding. Also keep in mind when we talk about drugs being eliminated into the breast milk that this can vary across classes of drugs. So for example, you can't assume that all, beta blockers are eliminated in the breast milk, or all beta blockers are not eliminated in the breast milk. It varies between specific drugs based on the chemical components of those drugs. So atenolol, for example, is a beta blocker that is secreted into the breast milk much more than metoprolol. So if you have a patient who you need to prescribe a beta blocker for and the patient is breastfeeding, then it's important to look through and see if you can find the one that's excreted the least into the breast milk. And then obviously check to make sure that even that little amount is okay, that it's been shown to be clinically okay in patients who are breastfeeding. All right, so this is where we left off. If you give the drug once, concentration goes up and then you clear it from the body and that's it. But if you give the drug repeatedly or continuously, then the drug starts to build up in the body. And it'll build up and accumulate in the body until you get to something called steady state. Steady state concentration is the concentration of the drug when the rate of administration equals the rate of elimination. So you're giving more drug, so more drug is going into the body and more drug is being metabolized out of the body, and it equals each other. So the amount in equals the amount out, and concentrations in the plasma and in the tissue remain relatively constant. There can be, little fluctuations throughout the day depending on when you're dosing it. But concentrations remain relatively stable when you're at steady state concentration. First, we'll talk about continuous infusions, and then we'll talk about interval dosing. So with a continuous IV infusion, the drug is being infused constantly, right? At a certain rate, the drug is just consistently going into the body at the same rate all the time. So the drug concentration is going to rise, steadily rise, until you get to steady state concentration. And then once you're at steady state, it's going to remain constant. When you're at steady state concentration, the infusion rate, so like how fast you're administering the drug, is directly proportional to the steady state concentration. If the infusion rate is doubled, if you give the drug faster, then the plasma concentration is doubled. The changing the rate does not change the time that it takes to get to steady state. Okay, so increasing the infusion rate increases the plasma concentration at steady state. It does not increase the time it takes to get to steady state concentration. Okay, the time that it takes to get to steady state concentration is the same. You're just going to increase the ultimate steady state concentration. Clearance is inversely proportional to steady state concentration. So like if clearance goes up, steady state concentration goes down. This graph just shows what we were talking about. On the bottom you have time, and over here you have plasma concentration. This lower line is showing you a low rate of infusion, right? You start giving the drug and it builds up, the concentration gets higher and higher and higher and higher, and then eventually you get to the point to where the same amount you're giving at the rate you're infusing it is the same as the rate the body's getting rid of it. And the two match each other, so the concentration remains steady. That's steady state. This other graph is showing you at a high rate of infusion. So now you're giving the drug faster. Essentially, you're giving more of the drug, per unit in time. So the concentration's higher. You're giving more drug, of course the concentration's higher. But it still takes the same amount of time to get to a steady state concentration. You're infusing the drug and the body's getting rid of it, and the concentration gets higher, higher, higher until eventually the two are equal. The body is metabolized, or the body is eliminating the drug at the same rate that you're infusing the drug, and that is steady state concentration. No, a faster rate of infusion doesn't change the amount of time it takes to get to steady state. It's still the same amount of time to get to steady state. It's about 4 to 5 half-lives. Different sources say different things, but for our purposes, we're going to say 4 to 5 half-lives to get to steady state concentration. When you doubled the infusion rate, you just doubled the actual concentration at steady state, but it still took the same amount of time. If you want to get to steady state faster, you have to give what's called a loading dose, which we'll talk about in a sec. The time to reach steady state, or the rate constant to achieve steady state, is the same as the rate constant to eliminate the drug from the body. So, which was half-life, right? Remember the rate constant for eliminating the drug we said was the half-life of the drug. So we see that after one half-life, the drug is 50% to steady state. It's like the opposite of when half-life eliminates the drug, right? You're at like your maximum concentration. After one half-life, you go half. And then after one half-life, you half that. One half-life, you half that. And it's always 50% less, right? But now it's the opposite. We're going the same rate, but now the concentration is getting higher and higher and higher. So after one half-life, the drug's at 50% of steady state. After two half-lives, it goes up half of that, right? So half of 50 is 25. So it goes from 50% to 75%. After three half-lives, it goes half of that, right? So like before it went up by 50, then it went up by 25. Now it's going to go up by half of 25, right? So 12.5, 75 plus 12.5 is 87.5. Now it's going to go up by half of that. So half of 12.5 is 6.25, right? Then it's going to go up by half of that. Eventually, we get so close to 100% that we'll say, okay, now the drug is at half-life, or sorry, now the drug is at steady state. Again, it's typically about 4 to 5 half-lives. We'll say, okay, now the drug is at steady state concentration, where the rate of infusion is about the same as the rate of elimination. So the only thing that affects time to steady state, or the only things that affect time to steady state, are things that affect half-life. So like volume of distribution, for example, protein binding, for example, those things affect half-life. So they're also going to affect time to steady state. When the infusion is stopped, the concentration is then going to decrease. And it's going to decrease at the same rate that it increased, right? Because remember, the rate constant's the same. So like the same exact rate that it went up, then it gets a steady state. If you stop the infusion, it'll go down at the exact same rate, right? Based on the half-life. We call that the washout period. Okay, so down here you see time, right? And then here you see concentration, and we see different infusion rates. Really quick, you guys notice that it takes the same amount of time to get to steady state for all of these drugs, right? I mean, really, like right here would be steady state. It takes about 24 hours for all of these drugs to get to steady state concentration, right? It doesn't matter what the infusion rate is. We see 3 different infusion rates. It still takes 24 hours to get to steady state concentration. The difference is the steady state concentrations are different. The faster or the more drug we infuse per unit time, the higher the steady state concentration is going to be. We said that after one half-life, the drug is at 50% of its steady state concentration. So I could figure out what the half-life is based on that, right? So for this drug, you can see the steady state concentration is about 200. So half of that concentration is 100. So let's see how long it takes for this drug to get to a concentration of 100, right? 100, come down. It took 4 hours. So the half-life for this drug is 4 hours. We could do that for any of them, right? Like for this infusion rate right here, 120 micrograms per hour, the steady state concentration is 100. Okay, so if we look at how long it takes to get to 50, 4 hours, right? The half-life is the same. The half-life is the same, so it takes them all the same amount of time to get to steady state, which is about 1, 2, 3, 4, 5 or so half-lives. This shows more like 5 to 6 half-lives. Again, different things will say 4 to 5, 5 to 6. We're going to stick to like 4 to 5 half-lives. So that was continuous infusion, right? When you're infusing a specific rate of the drug continuously. We also frequently, or even more frequently, give drugs in fixed dose, fixed time regimens, meaning like you could give 50 milligrams 3 times a day, or you can give 100 milligrams every 12 hours, right? That's a fixed dose, fixed time interval. If we administer medications at intervals, this results in time-dependent fluctuations in drug concentration. It's not a big, smooth climb in concentration, right? Like you'll give the drug and the concentration will go up, right? And then you start to metabolize it. And before it goes all the way down to nothing, you give it again. And the concentration kind of goes up, right? You start to metabolize it. And then before it's down, you give it again. And it kind of climbs until you get to steady state. And then at steady state, it looks like this. So it averages about the same concentration at steady state. But because you give the drug and then there's an interval, and then you give the drug and then there's an interval, it's not perfectly smooth like with the continuous infusion, but that's okay. If you adjust the dosing frequency of the drug, you adjust the amplitude of fluctuations. Right, so you adjust the size of these fluctuations as the serum levels increase. It does not change the rate to achieve steady state or the ultimate concentration at steady state. You're just affecting, how big the fluctuations are. So what I mean by that is like if I give 100 milligrams every 12 hours, or if I give 50 milligrams every 6 hours, they have the same drug. These are going to reach steady state at the same time, right? The steady state concentration is going to be the same. The only thing that's going to be different is how big the dose fluctuations are. If I'm giving 100 milligrams every 12 hours, the fluctuations will be bigger. If I'm giving 50 milligrams every 6 hours, the fluctuations will be smaller. Right? There will be more fluctuations because I'm giving it more frequently, but they'll be smaller fluctuations. If the dose is given orally, the concentration's impacted by the rate of absorption as well as the rate of elimination. Right? How fast do you take it in? How fast do you get rid of it? Here you guys see a couple graphs of fixed dose, fixed interval dosing. And you can see how the concentration kind of increases to get to steady state. Again, we don't even need to look at this one. But again, this 5 to 6 half-lives, we're going to just stick with 4 to 5, which this one is showing you, approximately 4 half-lives this drug took to get to steady state. So you see, you take the first dose, concentration increases as it's absorbed into the body, and then we start to eliminate it, and then it's time for the next dose. Concentration increases, we start to eliminate it, it's time for the next dose, right? And that continues. Here you see these are multiples of the elimination half-life, right? So after one half-life, we dosed it again. After another half-life, we dosed it again. Another half-life, we dosed it again. And eventually, after about 4 half-lives, you'll notice that we are at steady state concentration. And again, it's going to continue to fluctuate at steady state concentration, but it's, the average of those fluctuations is remaining steady. So the goal of a therapeutic regimen, when you're coming up with, what dose am I going to give this patient and how frequently am I going to give it? The goal is to get to a therapeutic concentration without getting to a toxic concentration. Drugs with a narrow therapeutic index have to be monitored very closely. Because again, a narrow therapeutic index means that there's not very much difference between the effective dose and the toxic dose. So when you get to the dose you want to be at, you're very close to a toxic dose, meaning any small fluctuation or any small change is going to be problematic. So you have to be very, very careful to make sure you're just at the right point and not over at all. Examples of drugs with narrow therapeutic index include drugs like digoxin and lithium. So how do we do this, right? How do we be really careful with these drugs? The way we do that is by drawing serum levels, right? So we, every so often you take a serum level of the drug. You take them more frequently in the beginning when you're first starting to give the drug. Because the initial regimen that you give is just a guess, right? It's based off of averages. What usually is okay for this specific patient, this size, whatever. And then you take serum levels just to make sure that everything's as you anticipated it and that the concentration is where you want it to be. And then you continue to take serum levels periodically because things change, right? The person's kidney function or liver function can change. Their overall size or ability to protein bind or other drugs that they take change. So we continue to do serum levels periodically to make sure that the concentration is where we want it to be, that it's therapeutic but not toxic. Now, in certain situations, we want to get to the therapeutic level quickly, right? We want to get to that steady state concentration, which is where we want the drug to be, quickly. And I told you guys that, increasing the frequency of the dose doesn't do that. Increasing the infusion rate isn't going to get to that steady state concentration quickly for us. So what we can do to get to a steady state concentration quickly is to give something called a loading dose, right? A loading dose. It's just that you load them up right away, and then you can start, giving the drug either by continuous infusion or your fixed interval dosing, which is referred to as the maintenance dose. So the loading dose is just a big initial dose that gets you up to that steady state concentration, that gets you up to that therapeutic level quickly. And then you can go on with your maintenance dose to try and stay there. So again, a loading dose is a large initial dose administered to attain desired plasma levels rapidly. We do this in serious situations. It's not a huge deal to do this if a person just has, a moderate hypertension or high cholesterol or whatever. But in some situations, a couple days matters, right? Like for a drug that has a half-life of 24 hours, it can take 4 days to get to steady state. That's a big deal if, the patient has a serious infection and you need to get to steady state right away. Or with arrhythmias where you need the patient or you need the drug to be at steady state right away so that you can monitor and make sure that the EKG shows what you want it to show before you, discharge the patient or let them go or whatever. So in these, serious situations, we give a loading dose. The disadvantage of giving a loading dose is that it increases the risk of toxicity. With, normal dosing regimens, the concentration slowly increases. So, say that this patient has a problem, eliminating or clearing this specific drug and the concentration goes up really quickly, we'll know that. Say this person has a sensitivity to the drug, we'll know that before the concentrations get really, really high. With a loading dose, you give a big dose right away, so you're like bombarding the system with the drug, and if the patient's going to react poorly to the drug, it's like, oops, I already gave you a huge dose of it. So it can be problematic. To calculate the loading dose, right, because it's like, how much do I give? To calculate the loading dose, it's the volume of distribution times whatever the desired steady state concentration is, divided by F. F stands for the fraction absorbed. F is just bioavailability. So if you're giving it IV, then the bioavailability is 1, right? Because all of it is absorbed. If you're giving it orally, then it could be, 0.9, 0.8, 0.65, 0.25, whatever the bioavailability is. After the loading dose is given to really quickly get you up to a high concentration, then the maintenance dose is given regularly in order to maintain steady state concentrations. Without a loading dose, it requires 4 to 5 half-lives to get to steady state. Okay, so you've got to give that maintenance dose numerous times before you're at steady state concentrations if you don't give a loading dose, which again is typically fine. The dosing rate is the desired concentration times the clearance of the drug over bioavailability. All right, so let's just finish up with a couple questions just to try and apply this information. All right, so a 64-year-old female who is 60 kilograms is treated with a drug for infection. The drug is available in tablets with an oral bioavailability of 90%. So 90% of the drug actually is absorbed into the plasma. The volume of distribution is 2 liters per kilogram, right? So that's based on kilograms. So we're going to have to use her weight here. And the desired steady state concentration, okay, so the concentration of this antibiotic that we're going to give is 3 milligrams per liter. That's what we need to get to in order for the antibiotic to be killed effectively. Or sorry, for the bacteria to be killed effectively. So which of the following is the most appropriate loading dose? So remember, loading dose equals volume of distribution times the concentration that we want at steady state, divided by the bioavailability. Right, so what's my loading dose for this patient? The volume of distribution, right, is 2 liters per kilogram, and this patient is 60 kilograms. Okay, so kilograms, 2 times 60 is 120 liters. That's a really high volume of distribution, right? So the drug distributes out into the tissues really well. So 120. So the loading dose is 120 liters times the concentration we want is 3 milligrams per liter, right? So liters is going to cross off, divided by the bioavailability, which is 0.9. So 120 times 3 is 360. 360 divided by 0.9. I don't know off the top of my head, but I can look at these numbers and tell you which, all right, it's got to be higher than 360, right? So 400 milligrams must be right. Right, so the loading dose that we're going to give so this patient can get up to steady state really quickly is going to be 400 milligrams of the drug. Then after that, we're going to give a steady, a smaller dose to continue, after the fact. Okay, so finally, optimization of the regimen. Again, I'll mention that the doses that we give initially are based off of averages. It's based on what the typical volume of distribution is, what the typical clearance is. This doesn't mean that all patients are going to obey these initial dosing regimens perfectly. They won't. So you do have to optimize the regimen. If the therapeutic levels are not achieved with the initial dosing regimen that you pick, you can calculate how much additional drug should I give to this patient, right? So say you do, your initial amounts, then you draw the therapeutic, you draw a serum level, and the patient's not quite where you want to be. Well, at that point, you're going to have to give more drug. But how much more drug? You don't just randomly pick a number, right? You don't just, let's give a little. Like, you need to figure out how much more drug do I need to give to get to where I want to be. And the additional amount needed can be calculated by volume of distribution times the difference between the concentration you want and the concentration you're at right now. Okay, it's pretty simple. If the patient is right now at 3 milligrams per liter and you want to be at 5 milligrams per liter, then you would just do the volume of distribution times the difference between those is 2 milligrams per liter. Okay? And that'll give you the volume distribution is going to be in liters. So that will end up giving you, you know, whatever additional amount that you need to get the patient to be where you want to be. Okay. All right, guys, that is it for kinetics.